Dr. Gina Makwabe, consultant physician and nephrologist working with AHN in Tanzania. So, Dr. Francis, please, can you take over?
Yes,
You're
thank you, Dr.
welcome.
Makwabe. Yes, good evening, everyone. May I take this time to introduce our speaker today, Professor Bhimma, Rajendra Bhimma, from KwaZulu-Natal in South Africa. He's a pediatric nephrologist and he's done a quite remarkable work. He's published more than 80 publications in peer-reviewed journals. He has authored 8 book chapters, and he has given more than 70 talks in international and local meetings. He's working as a pediatric nephrologist at Inkosi Albert Luthuli Central Hospital, as well as King George VIII Hospital. He's a member of faculty of University of KwaZulu-Natal, and he's also a member of Higher Degrees Committee, and he's a chairperson of Faculty of Research Committee at National Mandela School of Medicine, and he is also a chairperson of KwaZulu-Natal Transplant Panel. He is a recipient of International Society of Nephrology Fellowship, which he trained at Toronto Sick Children's Hospital in Canada, and he is also a holder of doctorate degree, Ph.D. This opportunity to welcome Professor Bhimma to give us a talk. Welcome, Professor Bhimma.
Thank you very much, Francis, for that kind introduction, and I hope I do justice to it. So I'm just going to start to share my screen, and as I'm talking to you, but just to let you know that I realize there's quite a few fellows on this talk as well, and so I try to keep it as simple and practical as possible, but often, would wander off into theoretical domains, and you don't want to do that. So I will start off by saying that some of the literature that we have may be overlapping with some of the adult work, but wherever that was so, I tried to remove it so that we concentrate purely on pediatric hypertension. Now, I have a few things to tell you that I left out neonatal hypertension because I think that's unique to just the pediatricians, and so it might not be of very great interest to the rest of us, so I specifically excluded that. And I also did not go into ambulatory blood pressure monitoring because I'm not sure how many of us have that facility. I don't have it here in Durban. I worked with it in Canada, but I don't have too much experience with it, and I didn't want to get into something that many of us may not have used before, particularly in the pediatric setting. And also with regards to pediatric emergencies, I just touched on it because that's a topic on its own. So with regards to today's talk, basically, the outline is going to be that I'm going to touch briefly on the prevalence of hypertension, and this is particularly in children in Africa, the definition of hypertension, its classification, some of the risk factors that predispose to hypertension, how we measure blood pressure in children, and that's the thing I want to concentrate on. Causes of pediatric hypertension, that means secondary causes of pediatric hypertension, clinical presentation in patients, some of the laboratory investigations that we do, and I'm not going to go into details of complex forms of hypertension, but rather stick to the ones that are more basic, and then touch briefly on treatment, and as I said, very briefly on hypertensive emergencies. So that is basically what's going to be the outline of my talk. At any time, if you have any questions or anything, please butt in and just ask me a question. I'll be happy to answer it. So what is blood pressure? We are doing a ward run. I asked one of my registrars, what is blood pressure? Basically, blood pressure is a pressure of the blood flow that is exerted on arterial walls by the heart, right? And it's a pressure that's produced by resistance of these vessels, which are mainly the arteries and arterioles, that is required for optimal body functioning. So we all did physiology, and you remember the formula that blood pressure is equal to cardiac output times the peripheral resistance. So the heart is pumping, and the resistance offered the blood by the arteries and arterioles, our blood pressure. And when that goes high, of course, we define that as hypertension. So what is defined as hypertension in children? Basically, it's not as simple as you have in adults, because here It is affected by the age of the patient, the sex of the patient, and the height center. Those are the three biometric parameters that impact on what is defined as normal blood pressure and hypertension in children. So it is a systolic and or diastolic blood pressure that's measured clinically that is greater than or equal to the 95th percentile corrected for these three biometric parameters. So that's the definition of hypertension in childhood, as opposed to adults where you have a single figure as 140/90. So why do we need to diagnose and treat hypertension in children? Okay. If you look at hypertension in adulthood, about 60% of them would have had hypertension as a child. So 60% of children with elevated blood pressure will progress to hypertension in adulthood. Hypertension in childhood, of course, is like in adults, a major risk factor for cardiovascular disease and chronic kidney disease. Death rates of children with chronic kidney failure is markedly higher than death rates in healthy children. So it impacts mortality. And then, of course, the major cause of mortality in these patients, like in adults, is cardiac events. So that is very, very important to note, and therefore it is imperative that we are able to detect and appropriately treat hypertension in children. What's the prevalence of hypertension in children? We don't have exact figures, but globally the prevalence of hypertension is increasing in all ages. It is estimated that both in adults and children there are over 1 billion people around the world that are hypertensive. And what is alarming for us coming from Africa is that there's an increase of hypertension in both adults and children in low and middle income countries. And there's various factors that impact on this, and we can discuss them later. There was a meta-analysis of data that was done of 25 studies in Africa involving 54,196 individuals who were between 1 and 19 years of age, who showed, and this study showed that hypertension rates varied between 5.5% to about 7.7%. And that elevated blood pressure was present in about 12.7% of children. So that's across Africa, okay? Now, in South Africa, another meta-analysis was done, and they estimated that hypertension rates vary in children. We had undertaken a study in 2016, and this was done as part of the World Kidney Day when it was dedicated to kidney diseases in children. And what we did in this study, it was very simple. We just went out to schools, and we didn't go to any of the private schools, because here in South Africa, we have a two-tiered schooling system. One is a private sector, which is mainly serving the more elite population. And then we have a public sector, which is for the general population. And so we went to all the schools, which are the public schools, right? And we took grade 12 learners and we measured the blood pressures, we measured the biometrics, the weight, the height, and we looked at what was the age. And we also did urine for protein creatinine ratios and did a dipsticks for glucometer readings. And then we analyzed this data, and this is what we found with respect to the study. We found pre-hypertension, I'll define this for you very soon, or what we call nowadays elevated blood pressure in 29.7%, which is almost twice the figure that I quoted to you previously in Africa. And hypertension in 13.7% of these grade 12 learners. And this is again very much greater than the 5.5% that I just quoted you in the earlier studies, which was the meta-analysis. Along with the way that the analysis was done, but on review of the analysis, it was perfectly correct. So this shows that hypertension in primary hypertension in childhood, we had excluded those that had chronic diseases or any other abnormality, and so looks like it is pretty high in our children in South Africa. What was most striking is that 15.9% of these children were overweight, and 13.3% were obese. And this is remember in public school, the lower socioeconomic group. Hypercholesterolemia was present in 10.8%, which was another surprising finding. They didn't have any other reason why they would have high cholesterol, but this was what we found. And doing a spot random urine albumin creatinine ratio, this was only evaluated in 1%. None of these children had elevated blood sugar levels, and both elevated blood pressure and hypertension in all learners showed a significant increase with increasing body mass index. So as you found that the weight went up, blood pressure went up almost in a linear fashion. And we showed that overweight and obesity were the major risk factors for the development of both elevated blood pressure and hypertension. And so, of course, this presages the need, or makes it absolutely pressing and urgent need for us to look at what are the factors that impact. And one of the main factors that came out was diet and lack of exercise in these children. Now, we did a questionnaire on diet and exercise, and if you look at what the diet of these children is, it is shocking. Over 80% of them, and we're going to still write up this data, over 80% of them do not carry home cooked meals. They have takeouts or other forms of fast foods that are there, things like soft drinks, which are loaded with sugar, and as well as a lot of sweets and chocolates, okay? And if you look at the exercise these children do, and we ask them how many of them, participate in sport, etc., the amount of exercise they do was only prevalent in about 17.6%. The others said they don't really exercise, etc. They just go straight from school, they go home, they relax, and then they do. Dietary indiscretions and lack of exercise play a major role for development of hypertension in these patients. So what are the types of hypertension we have in childhood? And this is something that, previously we never paid attention to, but nowadays is becoming increasingly more important. In that primary hypertension, which is defined as a blood pressure greater than the 95th centile for children, which is corrected for sex, age, and height, as I said, is now one of the most common cause of hypertension in childhood. I remember when I was a student, we were taught that if you get high blood pressure in children, always look for a secondary cause, because primary hypertension is exceedingly rare. And this is no longer true. It is very, very common. In fact, it's the commonest cause of hypertension in childhood. It's one of the major determinants of blood pressure, high blood pressure in these children. They often have a positive family history of hypertension, and usually it is the systolic blood pressure that's slightly more raised than the diastolic blood pressure. So those are all the factors that lead to development of primary hypertension, and a few others which we'll discuss later. If you look at secondary hypertension, this is where you have hypertension with an identifiable cause, then usually this occurs in preschool children, and the commonest cause, as previously noted, are renal and urological disorders, okay? And what's interesting that in secondary hypertension, it is usually the diastolic blood pressure that is slightly more raised than the systolic blood pressure. Then we have this entity of white coat hypertension, which we're all familiar with, even in adults. And this is, of course, like in adults, where you get a blood pressure reading in a child, which is greater than or equal to the 95th percentile in the office or clinical setting, but less than the 95th percentile outside the office or clinical setting, right? And this is where ambulatory blood pressure monitoring becomes important. And often you will have to confirm this by doing ambulatory blood pressure monitoring. And then we have the entity of masked hypertension. Now, masked hypertension is the presence of hypertension despite a normal office blood pressure reading. Right? So when the patient comes to you, they have normal blood pressure, but outside of that, they have hypertension. And once again, it is very difficult to know that unless you do one of two things, that is ambulatory blood pressure monitoring, or you get parents to be familiarized with how to do blood pressure readings in children at home, and they can record that, provided they do standardize the readings, you can then diagnose this condition. Have secondary forms of hypertension, that means hypertension where you have an identifiable cause, or in patients who are overweight and obese, right? And children with chronic kidney disease are at particular risk, okay? And that is important for us as pediatricians, because often when we treat hypertension in these chronic kidney disease patients, we don't know that whether the blood pressure is appropriately controlled at the clinic, and we say, okay, you're fine, but we don't know what's going on at home. And unfortunately, we all of us have access to ambulatory blood pressure monitoring, so we might not be able to pick up whether some of this is masked hypertension that we are missing. Now, what about the different criteria and the definitions of hypertension? So if you look at this cartoon here, there's Charlie that goes to his doctor and he says, the doctor says, Charlie, 130 over 85, your blood pressure is too high. So Charlie says, but sir, you told me that you need to keep it below 80 diastolic. Well, the doctor says the guidelines have just changed. And that's exactly what's happened in pediatrics, okay? So the guidelines for blood pressure has changed, and I must tell you, I am still grappling to understand this set of guidelines, which is a little bit complicated, but I'll go through it and tell you what it is about. You'll also appreciate some of the difficulties that the general pediatricians are facing to interpret blood pressure in children. With the new guidelines, in children that are aged 1 to 13 years, normal blood pressure is defined as any blood pressure less than the 90th percentile. Once again, it's corrected for age, sex, and height of the patient, right? If you look at those that are above 13 years of age, it is defined as a blood pressure of less than 120 over 80 millimeters of mercury. Then pre-hypertension is now changed to the terminology of elevated blood pressure. So what is elevated blood pressure? It is defined as a blood pressure that's greater than the 90th centile to the less than the 95th percentile, or 128 over 80 millimeters of mercury to less than the 95th percentile, whichever one is lower. Now, can you imagine sitting at the clinic and trying to work this out, okay, with your hypertension charts? It's a little bit complicated. And in over 13 years old, it's a little bit simpler. It's a blood pressure of 120 to less than 80 to 129 to less than 80 millimeters of mercury. If you look at hypertension, it's divided in stage 1 and stage 2. So stage 1 is where you get greater than 95th percentile to less than the 95th percentile plus 12 millimeters of mercury. So you have to measure blood pressure, work out what's the 95th percentile, and then add 12 millimeters of mercury to that and see whether the patient falls within that range. If he falls within, or he or she falls within that range, that is stage 1 hypertension, or alternatively, it is 130 over 80 to 130 over 89 millimeters of mercury. Now, whichever of the two is lower. And in greater than 13 years old, it is 130 over 80 to 139 over 89 millimeters of mercury. And if you look at stage 2 hypertension, whereas previously it was anyone above the 99th centile, and stage 1 was between 95th to the 99th centile, which was quite easy. Now, stage 2 hypertension is greater than 95th percentile plus 12 millimeters of mercury, or any blood pressure 140 over 90 millimeters of mercury, whichever is lower. And in over 13 years old, it's defined as a blood pressure of greater than 140 over 90. So this was an update from the National High Blood Pressure Education Program Working Group. And it was the figures that they defined from the fourth report on the diagnosis, evaluation, and treatment of high blood pressure in children and adolescents. Now, the fourth report was published in 2004, and this one came out in 2017. But if you look at the report, what's the impact of this report? And I won't go through that in detail, is basically it is now defining more children with a lower blood pressure, because in the first report, they also included children who are obese or overweight. This was children who had, in the second set of normative figures, they looked at children who were always below the 85th percentile for weight corrected for age and sex. So by using the new criteria, of course, the blood pressure readings are lower, and so more children are going to be diagnosed with hypertension. Now, that is very, very complicated. And so when these guidelines came out, I, in fact, commented on the guidelines. And what the authors did was then they looked at screening blood pressure values. Okay, and they came out with this set of figures where if you are sitting in the clinic, you can look at it and say, okay, for males, if you are years old, your systolic blood pressure shouldn't be above 100 and the diastolic blood pressure not above 50. So it is a much more simpler and manageable way of trying to define hypertension in this children. Okay, so if you are doing research, etc., you got to follow the original classification of the guidelines. But for the clinic setting, etc., I think that is too complicated. And so this chart here gives you some guidelines how to easily interpret blood pressure in the clinical setting. So those are the definitions that are now being used, which is based on the new normative figures. And as I said, based on these figures, you are able to diagnose hypertension in more children. So what are some of the risk factors for developing hypertension in childhood? And we've been through some of them, right? First and foremost coming out is obesity and overweight children, okay? If you look at children these days, and I look at what I had in my childhood, when we were kids and we came from school, the only time we spent at home was just the time that you drank your tea and ate a slice of bread or whatever. And thereafter, you were out in the fields, either playing soccer on the riverbank or on the farm, breaking mangoes or eating things. Nowadays, what are kids doing? They come home, they have something to eat or whatever it is. They're on the cell phones, they're on the laptops, they're on the iPads, or they are watching video games. And so the amount of physical activity that they're doing is very little. What they eat is often takeouts and refined sugar, etc. And that's of course contributing to overweight and obesity. And this is becoming a worse epidemic than what we're going to see, in the future than say HIV or anything. Chronic kidney disease is another risk factor. Family history of hypertension. Often these children, if you look at them, they have a family history of hypertension. Prematurity with low nephron mass, and that's in keeping with the Brenner hypothesis. Many children who are diagnosed with primary hypertension, in fact, if you take a detailed history from them with regards to the birth history, you'll find they were born premature. Anxiety is another one. I mean, I didn't realize how important this was until I started looking at carefully at blood pressure in my patients, and particularly in the students who are in the higher grades of school, grade 11, grade 12. They have a lot of pressure on them to produce good school marks, and they are very anxious, and they have a lot of anxiety. And if you send them to the psychologist and you send them for therapy, etc., and you manage them that way, you find that the blood pressure even corrects without any other further management with using drug therapy. So this is something that surprised me in my practice, and nowadays I'm paying much more attention to it. Excessive salt intake, this is not new, okay? We in South Africa have a sugar tax, but I think, we should really be imposing a salt tax as well. We have too many patients who are now eating fast foods and preserved foods, etc., because it's easier to prepare and easier to give to children in their lunch bags, etc. And I was listening to a talk once by a dietitian, and interesting enough, she made one very important comment. She said, if you find any food that comes in a box that is preserved, you know that that food is very high in salt. And that is true because the preservative is sodium benzoate, okay? So if you look at the amount of salt that we are taking in our diet, it's like about 3 to 5 times more than what we actually need. Caffeine intake, that's another predisposing factor, okay? A lot of these students want to keep awake because they want to study at night, and so the best way to do it is to take some of these power drinks, whatever they call them, okay? Or even coffee, okay? So or tea, they take in a lot of caffeine. Not surprisingly, as I discussed, sedentary lifestyles, they hardly playing sport. And in South Africa, I don't know what it is in other African countries, but in South Africa, some of this is also due to socioeconomic factors, right? There's in the lower income groups, there are not enough playgrounds, etc. But crime is a very important factor. In my setting at home, many parents are very scared to let their kids go out into the playgrounds after hours or when there's no adults around, because of the fact that crime is very high. And so they prefer their children staying indoors. And what can they do indoors? I mean, they only play on the cell phones or watch television, view television, or on the laptops. So sedentary lifestyle plays a very important role in the development of obesity and overweight in these patients. Dyslipidemia, surprisingly enough, comes with overweight and obesity. And so, like I showed in our study, we had about 10% of patients who had hypercholesterolemia. Disrupted glucose tolerance, we don't see that very often. We didn't have any in our cohort. And then sleep apnea syndrome. Okay, many of these patients, besides sleep apnea, many of these children, because they're under so much of pressure, they hardly sleeping well. And remember, if you have lack of sleep, that impacts on your blood pressure. So that's another factor in childhood that can predispose to hypertension. So these are all the factors that can lead to development of hypertension in childhood or contribute towards it. So how do we measure blood pressure in children? Now, blood pressure in children should be measured in the right arm at the level of the heart, unless, of course, there is some anatomical abnormality like an atypical aortic arch or something like that, right? But ideally, it should be measured in the right arm. And to do this, you should get the child to sit in a comfortable position for at least 3 to 5 minutes so the child is relaxed. Now, this is easy to say in theory, but very difficult to put into practice in young children, okay? You get a 3-year-old that comes to your clinic and you try and get the child to relax, you're not going to be able to do that, okay? All right, so we do our best to try and calm the child down, get the mother child on the mom's lap or whatever it is, and see that when the nurse is taking the blood pressure, it is actually done in the most optimal setting that we can get. What are the various methods that are used? Auscultatory method is the one that is promulgated as the gold standard. You can use aneroid blood pressure monitors, right? And of course, the one that is most common, popular, and easiest to use are the oscillatory methods, okay? And this is very helpful in that be able to listen to the Korotko sounds in small children, because sometimes it's difficult to hear them, right? Especially in the noisy environment. And it's very helpful, like I said, in preschool children or children that are non-cooperative. And of course, the auscultatory method is the most common method we use for screening for blood pressure. But whenever you pick up hypertension, the working group advocates that you confirm this by the auscultatory method. So remember, that is the commonest and easiest way to measure blood pressure, but not necessarily the most correct method. So when you measure blood pressure in children, as opposed to adults, well, I guess in adults also, if you have a very obese patient, you have to use a larger size cuff. You have to use the appropriate size cuff, right? And this is a nice chart that gives you the size of the cuff and the bladder length, width and bladder length of the cuff, the older children and adults. And as you can see, it varies considerably. Now, it's very important that you use the correct cuff size, because if you don't use the correct cuff size, you're going to get inaccurate readings. If you use a cuff that's too large, you get a too low reading. If you use a cuff that's too small, you're going to get too high reading, and you're going to diagnose hypertension, which is not even present. So what is the first step? To determine the proper cuff size, the cuff bladder width should be approximately 40% of the circumference of the arm. And how you measure that? You measure it from the point that is midway between the olecranon to the acromion. So there's a acromion process here and the olecranon, and so the length of the cuff should be at least 40% of that. Okay. What about the circumference? The circumference of the bladder should cover, of the cuff, should cover at least 80 to 100% of the circumference of the arm. At least 80% circulating, going around the arm, okay? The lower end should be placed about 2 to 3 centimeters above the antecubital fossa. And if you're doing it by the auscultatory method, then you should use the bell of the stethoscope, because it cuts out the extraneous sounds. And this should be placed directly over the brachial artery. And of course, you listen for the Korotko sound. And what sounds that we take are the first Korotko sound and the fourth, which is first appears, and the fourth is when, in fact, it totally disappears. Okay, so those are the things that we use to measure blood pressure in children. Now, if you look at the blood pressure measurements which are used for diagnosing hypertension in children, the first measurement should be performed using, as I said, an oscillatory device, because it's simple, it's easy to do, and it can be done by your nurse or someone else. But if you find it to be too high, and you should do at least 2 or more measurements. And if you do these measurements, you should then average out 3 of these measurements, and these measurements should be done at least 5 minutes apart. And if the average shows that it is above the 95th centile for corrected for age, sex, and height, then of course you do that, classify them as hypertensive. But one reading, one set of readings is not enough, and they advocate that you measure this at least. Now, often if we don't have the correct cuff size, etc., and we have a smaller cuff, I've noticed that some of the staff or even some of the nurses, what they try and do is wrap the cuff around the forearms or around the wrists and try and get a blood pressure reading. Now, you do get a reading, but it is not going to be accurate, and therefore you should avoid using that method of measuring blood pressure, especially in children, where you using a small cup size and you have a child who is obese or an older child and you don't have the right cup size. Please do not use that way of measuring blood pressure. Just a few notes about primary hypertension in childhood. As I said, it's the most common cause of hypertension in children and adolescents. And the type of children we see it in is usually the child that is school going, which is over 6 years of age. They often, as I said, have a family history of hypertension. Obesity and overweight are one of the most important factors that contribute towards the development of hypertension in this age group. And then, of course, as I said, they have mainly systolic hypertension as opposed to diastolic hypertension. If you look at secondary hypertension, on the other hand, kidney disease and renal vascular disease are the most common. If you find hypertension in childhood, it's still imperative that you exclude any secondary cause, and the first site that you look for are the kidneys. Therefore, I think in pediatrics, hypertension is mainly treated by nephrologists, whereas in adults, it's usually cardiovascular disease, and so it's mainly treated by the cardiologists. Okay. If you find secondary hypertension, it's usually in children less than 6 years of age, and often it is severe hypertension and quite often associated with end organ damage. So what are the common causes of secondary hypertension in childhood? And this is a familiar chart for all pediatricians. It is kidney disease, okay, chronic kidney disease, renal vascular hypertension, like things like fibromuscular dysplasia, Takayasu's, etc., coarctation of the aorta. Then there's a whole lot of endocrine factors that are associated with hypertension in childhood. And then, of course, you get monogenic forms of hypertension, and these are where you get things like Gordon syndrome and familial hyperaldosteronism, etc., which are associated with hypertension. I'm not going to go into details of this because I think this is something that pediatricians deal with all the time and are very familiar with, and you have to exclude secondary cause of hypertension in the child before you can diagnose the child as having primary hypertension. Now, we are very good at excluding the first couple, but when it comes to the monogenic types of hypertension, sometimes people have difficulty in diagnosing them because they don't have the appropriate tests available. And in some of them, they are associated with various genetic disorders, and genetic testing is expensive. And so we often do not make an accurate diagnosis as much as we would like to. If you look at common causes of secondary hypertension in childhood, and this is divided by age groups. In the newborn period, it is usually due to renal artery thrombosis or embolism or renal vein thrombosis, and then often congenital kidney malformations, or sometimes coarctation of the aorta, and not uncommonly in newborns who are ventilated for a long time for either like things like hyaline membrane disease, etc., they develop bronchopulmonary dysplasia. And of course, this is a very common cause of hypertension in this age group. In infancy to up to 6 years of age, once again, kidney diseases and renal vascular disease are very common. Once again, coarctation of the aorta is common. And of course, in this age group also, we must consider medications, especially if the child is on corticosteroids or beta-2 stimulants, etc., and given pseudoephedrine for asthma, whatever it is, okay? So just remember, you must take a detailed drug history in these patients, okay? And of course, endocrine causes must be excluded. Then in the 6 to 10 year age group, this is where we often start to see primary hypertension, But of course, we still have to exclude secondary cause of hypertension. And once again, renovascular diseases are the most common, but endocrine conditions and cardiac conditions also occur. And in the adolescent period, once again, we see rising incidence of primary hypertension. We also see white coat hypertension and mass hypertension. But of course, once again, needless to say, we have to include secondary cause of hypertension. Now, here, often drug history is very important, because I've had a few teenagers where I've picked up hypertension, and if you take a drug history for them and ask them, are you on any medication? You ask them, Mom, are you still on any medication? She says, nope, my daughter's not on anything, not for asthma, not for anything else. She's not taking cough mix, or she doesn't take that. However, when the child is counseled by the nurse, etc., two of them admitted that they were surreptitiously taking oral contraceptives. Okay, so remember, this is not an uncommon cause of hypertension in this age group. So just be careful of that. Okay, but once again, you have to exclude endocrine causes. So, what's our approach to diagnosis of hypertension in pattern that we do in adults? You look for symptoms of hypertension. Okay, the common ones that you see in adults also apply to childhood: dizziness, headache, palpitations, nosebleed, shortness of breath, visual problems, insomnia, etc. All of these are quite common in childhood. They are very non-specific, okay, except for palpitations, etc. If you find headache in a child, it is unusual for children to complain of headache. Please measure the blood pressure. That's very important, okay? And the other one that tell you, I feel very tired, okay, fatigue, which, yeah, sorry, it's fatigue. They tell you they feel very tired. So if a child comes with non-specific symptoms, etc., with any of these things, please measure the blood pressure. In fact, at every visit, it should be advised that you should measure the blood pressure. And if you find high blood pressure on more than 3 occasions and you average it out, then of course the child is hypertensive. Okay. So important things to look for in the history are other risk factors like overweight, obesity, the history of physical activity, eating habits, if they're taking in too much of salt, and in adolescent periods, etc., alcohol intake is very important. They don't often admit to it, but you have to be very careful, and you have to persist. And often the sympathetic nurse, many of these teenagers are admit to taking either alcohol or some other like oral contraceptives or something, which they will not admit to you, okay? Perinatal history is important because here, as I said, prematurity and predisposes because of the low nephron mass. There may be a history of oligohydramnios during pregnancy, suggestive of bilateral renal hyperplasia or dysplasia. Hypoxia, asphyxia with ventilation leading to bronchopulmonary. I mean, umbilical artery catheterization is often forthcoming if you look at the road to hell card. Other things are like urinary tract infections, and remember, many of them lead to renal scarring, etc., and predisposed to hypertension later in childhood. Of course, we must exclude systemic diseases. And like I said previously, look at your drug history very carefully, right? Many of these teenagers are pills or they are on other stimulants like beta-2 stimulants, etc., and caffeine intake is a very common thing that can predispose to hypertension. Not uncommonly, as I said, you'll find a family history, and that's very important, okay? And you need to know if they have previously been diagnosed with hypertension, at what age it started, what was the previous blood pressure measurements, and of course, you need to take a history of what drugs they have been on, etc., so that's going forward. So that's some of the history that you'll have to take. What about examination? And once again, the whole purpose of history and examination is to exclude secondary causes of hypertension, right? Besides the anthropometric measurements and looking at the body mass index, etc., you look on your general examination for features that may suggest underlying disease, like presence of edema, suggestive of kidney disease, Cushingoid appearance, which may be with endocrine factors, growth retardation, And then abdominal examination looking for the presence of a mass, which may suggest a renal tumor or adrenal tumor, hepatosplenomegaly, and which may suggest some form of systemic disease or sometimes found in polycystic kidney disease. Remember, both recessive and dominant forms of polycystic kidney disease. Cardiovascular examination, you want to examine the pulses to look for absent pulses, which may suggest either coarctation or sometimes like Takayasu's. And of course, you must measure the blood pressure in both the arms and the legs. That's very important because if you find a great differential, this will suggest of coarctation. Okay. You want to examine the heart fully to look for presence of cardiomegaly as a form of secondary end organ damage. And you want to look for other signs of left ventricular hypertrophy like a heaving eye, apex beat, etc. And of course, to check whether these patients are in cardiac failure or not. Okay. Then, of course, you want to look for neurocutaneous lesions and other features that may suggest a neurological disorder that may predispose to hypertension. And then, of course, endocrine factors, like let's examine the thyroid gland and other features that may suggest an endocrine disorder. And very importantly, when your neurological examination is fundoscopy, okay, looking for features of end organ damage, which is basically exudates and hemorrhages on the fundi. And then, of course, doing a full neurological examination to make sure that they don't have facial paralysis or any other features of a neurovascular deficit. So those are some of the factors that you look for on examination. As I said, the most important thing about the history and examination in a child with hypertension is mainly not just to diagnose the hypertension, but to look for other underlying diseases that may lead to what we call secondary hypertension. I'm not going to go into details of laboratory screening, but basically in all patients, we should do a urine analysis to look at presence of proteinuria, presence of hematuria, etc., as may look for underlying renal disease. And then there's a whole biochemical panel that should include the urea, electrolytes, creatinine. Of course, when you work like I do at the tertiary hospital, if all the simple causes of hypertension are excluded, then we start looking at more rare things, and then we start doing renin, aldosterone, etc., and more complicated tests to evaluate this child for monogenic causes of hypertension. And presently in the ward, I have a child who is very, very unusual. I mean, this child presented with nephrotic syndrome, was noted to be hypertensive, but on biopsy, this child has membranous nephropathy. So I said, well, that's not uncommon. You know, membranous can lead to hypertension. But when we looked at the biochemistry of this child has persistent hypokalemia and metabolic alkalosis. And then we did a TTKG and it came out low. And we did an aldosterone and renin level, and we got the aldosterone level back, and the aldosterone is low. So this child has classical features of what we call Liddle syndrome. Okay. Right, a little like syndrome, right? And I've never seen that before, but I must tell you that I was very surprised when we worked this child up for this to find this condition, which is exceedingly rare even in the pediatric group. It's like, I think it's much more common in adults than it is in childhood. And this is the first time I've seen it in a child who's got nephrotic syndrome, and not just nephrotic syndrome, but it's got idiopathic membranous nephropathy. So you can see that if you don't investigate these patients fully, you can often miss the diagnosis, okay? And I initially thought this was just due to the nephrotic syndrome. What about imaging studies? Simplest and easiest to do is a Doppler renal ultrasound looking for renal artery stenosis. And we do that, although the literature says used most common in children over 8 years of age, even in our younger children, we always do that as a routine. Of course, we also do a cardiac echo looking at the left ventricular mass for signs of end organ damage, and we look at the ejection fraction. And then very importantly, in pediatric hypertension as opposed to adults, the first sign of end organ damage is not the fundi or the kidneys. Often renal disease leads to hypertension, but it's the heart that's important. And here it is intraventricular septal hypertrophy that is very, very common for the interventricular wall thickness. CT angiograms and MRI angiograms, of course, are very useful for looking for renovascular disease, right? And the most sensitive being the CT angiogram, which is better than MRI. The problem, of course, is that you're exposing the child to much greater levels of radiation when you do this test, right? But it's a very sensitive test for diagnosing renal artery stenosis. And of course, if you're suspecting renal or other congenital abnormalities, looking at renography, which is isotope studies. And if you do split functions, you can look at the difference in function of both kidneys, and that way pick up renal scarring or renal dysplasia, right? And like I said, fundoscopy, I put it under imaging studies because of all of her patients with hypertension. We send them, besides us looking into the fundi, which ophthalmologists to do slit lamp examinations, etc., to look for hemorrhages, exudates, and disc edema. Okay, and this is maybe found in 18% of children who have very severe hypertension. Now, whenever you find end organ damage in a child and you're treating the hypertension, the recommendation is that every 6 to 12 months, you must repeat the examination to assess for progression of end organ disease. So that's the working groups. What are the treatment goals in managing hypertension in children, right? The most important objective is to, of course, prevent end organ damage. You don't want damage to your kidneys leading to chronic kidney failure. You don't want to have strokes. You don't want this child to develop hypertensive cardiomyopathy and congestive cardiac failure. So it's very important that you manage hypertension appropriately to prevent this. Now, remember that occurs both in secondary forms of hypertension, is aimed at less than 130 over 80 millimeters of mercury, or a systolic and diastolic blood pressure less than the 90th percentile, whichever one is the lower of the two, based on the initial diagnostic criteria that I gave you. So in a child who has chronic kidney disease but is not on dialysis, blood pressure lowering treatment is started when blood pressure is consistently above the 90th percentile for age, sex, and height. And the mean arterial blood pressure of less than the 50th percentile for age, sex, and disease, particularly those children who have proteinuria, of course, unless achieving these targets leads to signs and symptoms of hypertension. So the KDIGO recommendation is based on the ESCAPE study. And what is that you don't just aim for a blood pressure of less than the 90th centile, which is often your target blood pressure that you aim for when you have chronic kidney disease, but you aim for a lower blood pressure of less than the 50th centile, irrespective of whether it's proteinuric hypertension or not. And so that's the change in the recommendation that we have. This is just an algorithm. If you have a blood pressure that is high via the oscillatory or auscultatory method, of course, you repeat it twice and you average it out. And if it's still elevated, you do it on more than 2 occasions. And if it's still elevated, you then have to evaluate this child and you have to classify the blood pressure based on those normative values that I gave you, right? If it's still elevated, you have to take a detailed history and you start with lifestyle counseling, and of course you repeat in 6 months' time. We don't wait for 6 months. We actually call the child back in the next month and start to evaluate. If, on the other hand, there is stage 1 hypertension, you have lifestyle counseling and they recommend that you repeat this in 1 to 2 weeks. And if it's still high, of course, you go ahead and manage the patient appropriately, whether that's just purely non-pharmacological treatment with lifestyle changes or whether it involves medication, depending on what you find. If, however, there is stage 2 hypertension, you initiate evaluation and treatment. And of course, these are the patients that gets referred to a pediatric nephrologist for further workup. Of course, if you have symptomatic hypertension with stage 2 hypertension, then this requires emergency treatment. Okay, so that's just the approach that we use and give to our general pediatricians for how they should approach hypertension in childhood. Then we come to the management. Okay, now management, like in adulthood, is divided into 2 main groups. One is lifestyle modification and the other one is pharmacological treatment. Okay, now if you look at lifestyle modifications, and I think I alluded to this earlier in the talk, salt restriction is very, very important. Okay, if you look at the diets of children that we are having, even children coming in our setting in South Africa from a lower socioeconomic group, the diet has completely changed over the years. Okay, and many of them are now eating food from fast food outlets, etc. And remember, fast foods are tasty for two reasons. They have a high fat content and they have a high salt content. So you have to restrict sodium to less than 3 grams a day. And that's very difficult. Even I find it hard, okay? The amount of salt that we take in our diet. So you try and restrict salt by restricting fast foods and by restricting the amount of salt they put into their salads, etc. And one of the other things that kids are very often used, it's a flavoring that's used in foods, etc. And it makes food tasty, but it's got a high salt content. So we advise parents to stop the use of these food flavoring agents. Then you look at the dietary approach to stop hypertension. That's the DASH type of diet, where they advise that you increase the olive oil rather than cooking in the usual vegetable oils that we use. You increase your fruit and vegetable intake. You use milk, which is low-fat milk products. You increase your whole grain and nuts intakes in the diet. And for non-vegetarians, if you're looking at meat intake, you encourage parents to use lean meat or white meat for the diet in children rather than using red meat, which has a high fat content. This is from the adult recommendation and also extrapolated into pediatrics, that you encourage exercise of at least 30 to 60 minutes 3 to 5 times weekly. Okay, and like I said, if you look at children these days, they hardly ever exercise, because of security reasons. Parents pick them up using a car, drop them at school, then pick them back again and bring them home. And so these kids are hardly getting to walk. Okay, and if they play sports, it's only for the 1 or 2 hours they're there at school. But outside of that, they hardly get any physical activity. So we have to do something to encourage physical activity in these patients. And of course, very important to stop unsavory habits. By unsavory habits, I mean recreational drugs. And this is something that I didn't bring up, which I should, that if you look at the teenagers, many of them are taking recreational drugs. And by recreational drugs, I mean actually illicit drugs like marijuana, which is a very common thing. And some of them are even taking much stronger recreational agents. And so we have to be very careful that we are not missing this and take a detailed history. And often I get a psychologist involved and a social worker involved to take this history because they feel more comfortable talking to these children. And I've come across now about at least 5 patients who've been taking recreational drugs who have high blood pressure. And once you stop this, the blood pressure normalizes. Smoking is another common factor that we find, and of course, alcohol intake. Okay. And then lastly, but not least, in the young children, licorice. And I was surprised that licorice plays a role in the development of hypertension. And I had a patient who was referred to me by one of the general pediatricians because after minor surgery, he found the blood pressure was elevated. I evaluated the child, did every possible test, could not find anything, until one day I was walked into the ward to do a ward round, and there's this child sitting with a whole bowl full of jelly babies and licorice. And I asked the mom, do you often give this child? She said, oh, of course, doctor, he loves it. He eats it all the time. I mean, he eats it more than he eats food. Boom. Then the penny dropped. I said to mom, please, will you stop giving this child licorice and try and reduce it? And as we did that, the blood pressure normalized. Required no treatment. So licorice is something that leads to high blood pressure, especially in children. And then, of course, if you've come to pharmacological treatment, okay? If we fail with lifestyle modification, so we don't have anything in the history or with lifestyle that, or whether we modify everything and we're still not winning with the blood pressure, then of course we have to institute pharmacological treatment. Of course, if you have symptomatic hypertension, that must be done straight away. If you have stage 2 hypertension, of course, you have to institute. Not that you're not going to do lifestyle modification, you do it pari passu with your pharmacological treatment, right? And of course, if you have end organ damage, once again, pharmacological treatment is warranted early on in the course of the management. What are some of the important considerations we take regarding drug treatment? You should initiate drug therapy using the lowest dose possible as initial treatment because of course you're worried about hypotension or adverse effects, right? And once you institute treatment, you should measure the blood pressure at 2 to 4 week intervals. And of course, you increase the dose if the blood pressure hasn't reached the target value, which is less than, gradually aiming to drop the blood pressure below the 50th centile. Of course, we must pay attention to adverse effects, okay? And if you experience any of this, you can either consider reducing the drug and adding another agent, or if it's very severe, stopping the drug completely and starting with another agent. And second line treatments is added, of course, if the blood pressure is not controlled and you've reached maximum doses of your first agent. Remember, the more agents you introduce, the more the side effects, and unfortunately less the adherence to drug treatment, okay? You know, it's hard enough to get adults to adhere to treatment. I mean, try that in teenagers and you'll win the Nobel Prize if you can get them to be completely adherent. You consider second line treatment if there's no contraindication, because often we use calcium ion antagonists as first line of treatment. And remember, one of the side effects of calcium ion antagonists is that they cause salt and water retention, okay? And then after the blood pressure target has been reached, you should continue to evaluate these children at least 3 to 4 months intervals. That's the recommendation by the working group, okay? With regards to children with chronic kidney disease who are not on dialysis or diabetic patients, angiotensin converting enzyme inhibitors and angiotensin receptor blockers are the treatment of choice as first line treatment, irrespective of whether these patients are proteinuric or not, okay? So there's a whole list of agents that we can use, and it's very similar to what we use in adults, but I'll come to that a little later. The American Academy of Pediatrics suggests that first-line treatment should be either a angiotensin converting enzyme inhibitor or an angiotensin receptor blocker or a calcium channel blocker, and preferably you should use a long-acting calcium channel blocker. Example is like a drug like amlodipine. The problem is in many of the district hospitals and regional hospitals, because of the cost of these agents, they are not very readily available. And so I advise these doctors to start off with a diuretic, which is pretty cheap, or a vasodilating agent like hydralazine, but use diuretics as the first line agent, okay, if the others are not available. The American Academy of Pediatrics does not recommend beta blockers as first line, and we also don't use it as first line because our patients, predominantly Black African patients, for some reason are somewhat resistant to beta blockers, and they don't work very well in our group of patients. So we use either calcium channel blocker or diuretics as first line together with ACE. Now just remember, if you have teenage patients, etc., and you're considering using either a receptor blocker or a angiotensin converting enzyme inhibitor, you must exclude pregnancy because these drugs are teratogenic, okay? So it's very important that you exclude pregnancy in these patients, right? The other agents like alpha blockers and vasodilators, clonidine and minoxidil, are only used for the management of resistant hypertension. We do not use it as first-line therapy in these patients. And I tell my doctors at the district hospital that if you've used a thiazide diuretic or a calcium channel blocker and you're not getting good effect and you've added ACE, and if the child is still not responding, please refer the child to the central hospital for further evaluation and treatment. This is just a chart of some of the antihypertensive agents that are available. And like I said, it's very similar to what you use in adults. The ACE inhibitors, the ARBs, calcium channel blockers, diuretics, beta blockers, and alpha blockers, etc. And that's the dosaging and some of the side effects that are associated with that. But I'm not going to go into details of each one of these things. I just put it on for you to know that it's very similar to what you use in adults. Now, what about treatment-resistant hypertension? Now, what is defined as treatment-resistant hypertension is similar to what you have in adults. It's basically persistent of hypertension despite intake of 3 or more antihypertensive drugs at the highest level. And you ensure that treatment is received at the recommended doses and not above those doses or below those doses, because if you optimize treatment, what is also very important in pediatrics is dosing frequency. Now, if you look at the literature, for instance, for drugs like calcium channel blockers, long-acting ones like amlodipine, the recommendation in adults is that you use it once a day, okay? Children metabolize at a much faster rate, and I haven't published this and my friend hasn't published it either, but often we use the drug twice a day and we get reasonably good control of blood pressure, and that's because children metabolize much faster, okay? So we get good control of blood pressure by using the drug twice a day and dividing the dose up rather than using it once a day. And if you're using multiple drugs, it is important that you stagger the treatment. So you don't give all the medication at a single time, okay? Especially if you're using more than 2 drugs. Otherwise, what happens is you get control of blood pressure the minute you give it, and thereafter you get a rebound hypertension. Always consider renal vascular hypertension. Childhood, as I said, is the commonest cause, especially if you have resistant hypertension, right? And of course, ambulatory blood pressure measurements should be used to confirm the diagnosis of resistant hypertension. Now, we don't have access to this, but that is what's given by the working group. And in all regimens, if you have resistant hypertension, you should include a diuretic, okay? That's the recommendation by the working group, okay? And if you have secondary hyperaldosteronism, then a good drug to use is something like spironolactone, because of course it works on the blocks aldosterone, and so in that way you would decrease volume excess and then get control of your hypertension. So these are some of the things about resistant hypertension in childhood. There's a lot more detail, but I'm not going to go into that because of time constraints, and also is specific only for the tertiary institutions. Just briefly to touch on hypertensive emergencies. Of course, this is any life-threatening condition related to your hypertension. And this should be considered if you have a blood pressure which is of mercury, right? And of course, if you have signs of end organ damage, like central nervous system effects like headaches, nausea, vomiting, confusion, visual symptoms, etc. If you have cardiac effects like congestive cardiac failure or signs of left ventricular hypertrophy, and of course in children who have chronic kidney disease, okay, or even acute kidney injury, which may or may not be proteinuria. Usually there's an underlying secondary cause for this hypertension when you have a hypertensive emergency, and the most common is kidney related causes, either acute kidney injury or chronic kidney disease. And then of course, sometimes you might find endocrine or even cardiac causes, okay? And when you do fundoscopy in these patients, you may find hemorrhages, exudates, or papilledema. And if this child presents with CNS symptoms, especially those who will diagnose PRES, which is posterior reversible encephalopathy syndrome, okay? Now, that's a whole lecture on its own, so I'm not going to go into details of it, but basically, if you manage these patients, they have to be managed in a high care unit, in an intensive care unit, where you can use intravenous antihypertensive agents, okay? Now, use of intravenous antihypertensive agents should not be taken by anyone who's not skilled with giving these drugs, because if you do not monitor, it can cause severe hypotension, and that can lead to a stroke in these patients, okay, or congestive cardiac failure. So you have to be quite skilled at giving this in children. How do you reduce the blood pressure? The working group recommends that in the first 8 hours, you aim for 25% reduction in blood pressure. And then over the next 12 to 24 hours, you should try and target for a blood pressure that is around the 95th centile, okay? So it follows a principle of what I remember one of my professors used to say, festina lente in Latin. That means hurry up slowly, okay? Now, you realize that's an oxymoron. You can't hurry up slowly, but it is exactly what it is. In other words, you don't want to rapidly reduce the blood pressure to normal. You want to gradually bring it down, because of course, you can precipitate a stroke or congestive cardiac failure in these patients. So if you have a hypertensive crisis, you work out whether it's an emergency or an urgency. What's the difference between an emergency and an urgency is basically symptoms of end organ damage, okay? If you have, say, headaches and convulsions, which is the most common thing that they present with, or you have visual disturbance, etc., any end organ thing will make it an emergency, okay? If you just have a high blood pressure, a blood pressure that's very high, but no signs or symptoms of end organ damage, then it's defined as an urgency. Have an urgency, you can, apart from if you are not able to get this child into an intensive care, is the blood pressure to around the 95th centile, okay? And once you reach that kind of target blood pressure, then you start introducing your oral antihypertensive agents so that you can start weaning off your intravenous agents and gradually bring the blood pressure down to your targeted blood pressure, which is less than the 95th centile. And then as time goes on and you follow the patient up, you aim for the 90th centile. What are the common drugs that we use for treating hypertensive emergencies? And what I did was available in South Africa, but I'm not sure what you have in the rest of Africa. The drug of choice that we use is labetalol, okay? Provided, of course, there's no contraindication. That means the child's not in heart failure, the child's not severely known to be severely asthmatic, or the child doesn't have bradycardia. This is an alpha beta blocker, and the good thing about giving labetalol is that it gives you a very graduated drop in your blood pressure level. You can titrate the dose, and provided there's no contraindications, I haven't seen any major side effects from it. Of course, if you have children who have severe volume overload, which is contributing to the blood pressure, then the use of intravenous furosemide is together or on its own is the agent of choice. Other agents that we have available are sodium nitroprusside, but remember, if you're giving sodium nitroprusside, this can drop your blood pressure quite precipitously. I've used it on 2 or 3 occasions, but you have to be very careful that you do not give it too rapidly. And remember that it has a side effect that would administration for more than 24-48 hours, you got to measure your cyanide level because of thiocyanide toxicity, okay? And administering this drug also is very important. The way you do it, you have to make sure that it's protected from sunlight, etc. Otherwise, it increases the risk of cyanide toxicity. Other drug is hydralazine. The thing about hydralazine is I've had to use it on one occasion, and this occasion, this child came in convulsing with a hypertensive crisis, and we couldn't get up a central venous line on this child because it was very difficult. We tried, but in the meantime, this child was convulsing. I controlled the convulsion, and you can give this drug intramuscularly. Make sure that you use a good sized needle. You don't, because this in an obese patient, this you might end up giving it into fat, and of course, if you give it in fat, it's not going to be absorbed rapidly. But if you give it into muscle, it is even intramuscularly, it's quite rapidly absorbed, and you can control the blood pressure quite well. Of course, the ideal is then to get our central line up and use an intravenous agent and give it either intravenously or use another agent. So those are the common drugs we have available. And in patients who have a hypertensive urgency but no end organ damage, of course, we use oral nifedipine. Now, the recommendation, most people when they're using nifedipine will say you have to give it sublingually because it works very rapidly and brings down the blood pressure. That has now been disproven. Whether you give it orally or sublingually, it works equally well. The problem with using it is that you can't predict how much it's going to drop the blood pressure, right? So you can get severe hypotension from it if you give a very high dose. So 5 milligrams per kilogram per dose, and you can repeat that dose every half an hour or every 20 minutes until you start getting a reduction in your blood pressure value. The problem with nifedipine, of course, being a calcium ion antagonist, short acting, is that it can cause quite severe reflex tachycardia. So you should have these patients on a ECG monitor. So what can we say in conclusion then is that basically pediatric hypertension arises. It needs early identification, appropriate management, and the children are at high risk and has to be screened at each contact. You have to target schools for lifestyle changes, and this must include dietary changes. And of course, with using the new clinical practice guidelines, Our aim is to improve the recognition, evaluation, and treatment of these children and adolescents so that they don't end up with end organ damage as adults. Ladies and gentlemen, thank you very much.